right, I guess we should get going here. Thank you everybody for joining us for another AO fellow webinar. This time it's being hosted by the University of Buffalo. Myself, Jeff Mullin, and my partner John Polina will be moderating with some of our fellows and residents presenting some information on flatback deformities today. Next slide. So as I said here, our current presenters will be Justice Agyei, Tim O'Connor, and Robert Starling. We're going to go over the also, we have no disclosures pertinent to this talk. And then quick agenda for this evening, my introduction here, and then Dr. Starling's going to be going over the initial discussion on flatback deformity, followed by Dr. Agyei going over some of the open correction techniques, and Dr. Connor with the more minimally invasive approach, and then a dedicated question and answer session. I'll wrap it up then. For the question and answer session, if you want to save your questions to the end, that's fine. Also, there's a question answer function in Zoom. We'll be answering those throughout the talk as well. And just one last plug before we get going here. Please mark your calendars that next month's talk will be, I think Dr. Kleiberg is doing that one, and I'm not sure who's doing the one in March, but both another good series coming up. So before we go, and hopefully that by the end of this talk, you guys understand pathophysiology and are able to describe flatback syndrome, go over the intervention techniques, whether it be open or minimally invasive, and be able to discuss the drawbacks and benefits of those different options. Without further ado, here's Dr. Starling.
Okay, welcome everybody. So flatback syndrome, our topic today. So it's most often described as a loss of lumbar lordosis after a thoracolumbar fusion. This was first identified in patients with Harrington rod instrumentation, the reasons which we'll get into. There are other causes that are less common. Associated factors can include things like other distraction instrumentation, like the aforementioned Harrington rods and other distracting instrumentation, hip flexion contractures, thoracic hyperkyphosis, and pseudoarthrosis. Most of the time when we're discussing flatback syndrome, we are talking about iatrogenic causes. It can be divided into flexed or fixed sagittal deformity based on how correctable the deformity is with positioning or posture. So what exactly causes flatback syndrome? Well, usually it's us. So most of the time we see this in patients who've had distraction instrumentation such as Harrington rods, or even more commonly used nowadays instrumentation where distraction forces have been placed over the lower lumbar sacral levels. This increases the risk of developing this problem. So you're failing to maintain or even increase their preoperative lumbar lordosis after you are instrumenting them. And then, of course, breakdown in that lumbar lordosis that you're attempting to create or maintain can result in poor alignment. So most of the time this occurs with instrumentation. Occasionally, you'll see cases where patients have had simple decompressions that, due to degenerative changes, have also had a failure of or had a loss of lordosis. But this is certainly the most common cause, and one which most studies focus on. So what do we do for this? Well, as you can imagine, since this is something that we cause, the most effective treatment is to prevent it in the first place with the index operation. How do we do that? So first is by paying attention to their spinal pelvic parameters, their current preoperative alignment, and by obtaining 3-foot standing films and calculating their current SVA and their goal lumbar lordosis. Avoiding distraction instrumentation in the lower lumbar spine is also important. So even in cases where you're attempting to, say, correct a coronal malalignment and you're providing some distraction on one side of the instrumentation, paying attention to the overall lordosis that you're attempting to maintain in that patient. Other things, more commonly used nowadays, a Jackson table or another table that allows for accentuation of their natural lumbar lordosis, as opposed to older table types, which fail to allow for this. Positioning to accentuate lordosis can also be important. So hyperextending the hips while you're positioning can increase your ability to create lordosis or maintain it during the procedure. So what other things can you do in terms of conservative management? So physical therapy, as always, these things can help increase hip and back extension. You can use NSAIDs for, symptomatic management. Chiropractic manipulation can be helpful. There are devices that have been created, such as the one shown on the right here, which is a lumbar extension and traction device. Essentially, places them in a lordotic position for an extended period of time. Most of these are used in mild to moderate cases or cases in which there's still some flexibility to the deformity. However, there's a series of patients by Farsi and Schwab which found that only 27% of these patients were successfully managed with conservative measures. They were also noted to have an SVA of about 3.4 centimeters, so certainly a relatively normal compared to the patients who failed conservative management, had a relatively normal SVA, and they had intact disc below the level of diffusion. So these were a less severely affected subgroup. The remainder did require surgical correction, and that's will be the main point of discussion today, is what are the different options for surgical correction, and just keep bearing in mind that the goal when we're doing these original, the index procedure for any of these patients is to maintain or increase their lordosis. We have our first polling question here. So how often do you get 3-foot standing films in patients with thoracolumbar pathology in which you are considering a fusion?
You should poll. Oh, there you go.
There we go.
Wow. Okay.
All right, great.
All right. So my name is my name is Justice Agyei. I'll be presenting the operative open techniques for correcting flatback deformity. So I will start off with two cases and then jump into the presentation after. The first case is a 50-year-old female who presented to us after multiple lumbar surgeries, with the last one being L2 to 3 fusion in 2015. She came to us with severe low back pain. Her pain was exacerbated by standing upright and ambulating, and she got to a point where she required a walking stick for ambulation. She denied any radicular pain or paresthesias. Her past medical history was unremarkable, and as I said before, she had multiple lumbar surgeries. On exam, she was non-focal, but did have antalgic gait. This is her MRI, and it demonstrates her prior L2-3 fusion, but at the adjacent level at L1-2, you can see there's degeneration with a broad-based disc herniation with significant stenosis at that level. And also significant is the extent of her lumbar surgeries, which is apparent here. This is her CT scan, which again demonstrates fusion mass bilaterally from L2 down, L2 down to L5 with an open space at L12. This is her standing scoliosis film, which demonstrates clear-cut flatback deformity with straightening or flattening of her thoracic kyphosis. And she has an SVA of 7 centimeters with a lumbopelvic mismatch of 27 degrees. The second case is a 72-year-old male with also multiple previous lumbar surgeries presenting with low back pain. His pain was worse when he stood upright and reports having to lean forward in order to get relief. He also reports only being able to ambulate short distances. His past medical history was unremarkable, and surgical history is significant for multiple lumbar surgeries, with the last one being L2 to 5 laminectomies and non-instrumental fusion in 2014. In his exam, he has a right foot drop, otherwise full strength, and has a leaning posture when he's standing upright. And this is his CT scan, which demonstrates bilateral fusion masses from L2 to L5. It is important to note that he does not have a fusion across L5S1, across the L5S1 level. And this is his standing scoliosis film, which demonstrates severe flat back deformity with an accentuated thoracic kyphosis. And when you do his measurements, he has an SVA of 21 with a significant pelvic incidence 66.6 with a lumbopelvic mismatch of 30.6. So this gentleman has pretty significant flat back deformity with an accentuated flexible thoracic kyphosis. So jumping into my talk, the statement for this talk is life is a kyphosing event. As we age, our ligaments weaken, and so we lose our natural lumbar lordosis and gain an increase in thoracic kyphosis, which ultimately leads to us leaning forward or falling forward as we age. And if we're going to treat flat back syndrome, it is important to look at the normal spinal anatomy. And the point that I want us to pay the closest attention to is where we get most of our lumbar lordosis. And this will tell you, this picture that I have here shows you that the lumbar lordosis from L4 to S1 accounts for about approximately 70% of your overall lumbar lordosis. And with that in mind, that should give you an idea of where you can get the maximum correction when operating on patients with flat back deformity. It is also important to know that not all spines are created equally. And some patients will have higher pelvic incidence than others. And with higher pelvic incidence, also these patients require a higher lumbar lordosis, as well as which is compensated also by a higher thoracic kyphosis in order to maintain the head on the pelvis. And so when treating patients, it's important to have an overall understanding of their lumbopelvic parameters before operating on. And these measurements have been shown time and again to have a significant impact on patient health outcomes. This study by Glassman shows that patients with overall increase positive sagittal balance had a decrease in their mean SF12 scores, as well as an increase in their mean ODI scores, which is huge when taking care of these patients. Schwab and his colleagues did a radiographical analysis of spinal pelvic parameters in a setting of adult spinal deformity. And what they found was a few parameters to help patients in terms of helping them with their overall health outcomes. And a few of the parameters they found was when they kept patients' lumbopelvic mismatch under 11 degrees, pelvic tilt under 22 degrees, and SVA less than or within 4.6 centimeters or 46 millimeters, they found that these patients overall had a lower ODI scores and overall better health outcomes. Now, those numbers are very important to keep in mind when taking care of these patients. However, like I said before, life is a kyphosing event. And so a 45-year-old spine will not behave the same as a 75-year-old spine. And so this study basically shows different age-adjusted parameters that we need to take into account as we take care of patients, especially knowing that most of these cases occur in the elderly population. When we do treat these patients, there are a few goals that we keep in mind. And the first and foremost is to prevent progression of the patient's deformity. The next would be to decompress any neural elements and restore the appropriate sagittal, coronal, and rotational alignment. Next would be to stabilize the patient, and most importantly, to avoid any complications. And the different techniques we use can be broken up into minimally invasive versus open approaches. And for minimally invasive, we have anterior approaches as well as direct lateral approaches for inner body placement. But there's also posterior lateral fusion. These are basically the traditional neurosurgery bread and butter for placing inner body and attempting to improve lordosis. However, what I consider to be basically the workhorse of any deformity surgery is these osteotomies, which is on the right, I have the Schwab classification systems, but just to break it down to the most important facts or the basic tenets of these is, the Smith-Peterson osteotomy, pedicle subtraction osteotomy, vertebral column resection. And I have to the side of them the amount of lordosis one can hope to achieve after performing these procedures. And these are the approximations, and basically can vary depending on how these techniques are performed. And lastly, these procedures or techniques can all be used in conjunction with the other, and one does not need to be done in isolation. So another important step when it comes to taking care of these patients is determining when and where to perform osteotomy. So when it comes to iatrogenic flat back, two things that we have to pay attention to is the degree of thoracolumbar alignment, which, whether the patient has thoracolumbar kyphosis or accentuated thoracolumbar kyphosis or not. And the next is whether they have a flexible or rigid deformity. So in patients with flat back without any thoracolumbar kyphosis, one can perform lumbar osteotomies below the conus and may be able to achieve correction of that deformity. However, when the patient does have an accentuated thoracic kyphosis, it is important to distinguish whether the kyphosis is flexible or rigid. And if it's flexible, then one can extend the fusion into the thoracic region without performing any osteotomies. Whereas if it's rigid, then we would have to perform lumbar and thoracic osteotomies in order to correct the deformity. So lastly, I want to talk about some outcome measures, outcome studies after following deformity surgery for correction. And the largest study is the ScolioRisk 1 study, which was performed by Lenke. And in this study, they found that this procedure is associated with high morbidity, but also associated with a relatively higher incidence of neurologic post-op neurologic decline, although a lot of these patients will improve over time. And the most important things to take from that is the risk factors associated with those complications was number one was the patient's age, the lumbar level of osteotomy that was performed, and whether the patient received a 3-column osteotomy or not. And all this together ties into the how much blood the patient loses during a procedure, which can significantly impact the patient's outcome. So now returning to our cases, we're going to first go over the 50-year-old who had the prior L2-3 posterolateral instrumentation, coming in with severe back pain, with a fusion mass from L2 through L5, and with flatback deformity with what appears to be a flexible thoracic spine. The patient's lumbopelvic mismatch is 27 degrees. And I guess the question here is, what would you do for this patient? This goes out to the audience. All right. So I guess we basically went along with what most of the audience were thinking. We performed an extended L4 PSO with bilateral S2AI fixations and bilateral S1 SI joint fusions with fusion extension up to T11. And after the surgery, you can see there's great restoration of the patient's lumbar lordosis, and the mismatch was brought down from 27 to 8 degrees with, and also significant improvement in the patient's SVA. Her post-op course, she continues to have some back pain. However, it's improved from preoperative baseline, and the patient's ambulating independently and undergoing aquatic therapy. So the second case, this is our gentleman, multiple lumbar surgeries with a fusion mass from L2 to L5. And I mentioned before, the important one of the things to take into consideration is this open space at L5S1, and also taking into account what I mentioned before about the where we get most of our lumbar lordosis from. With all that in mind, what would everyone do for this patient? All right, that's great, because that's exactly what we did. So we did a combined procedure, except we staged it. So we did an L5S1 ALIF, and you could see already there was a significant degree of correction in the patient's lumbar lordosis and overall lumbopelvic mismatch. And then we took the patient back for posterior osteotomies. We did L1, 2, L2, 3, and L5S1 Smith-Peterson osteotomies, and performed a fusion from T11 to pelvis. And these are the patient's results. After this, you can see the lumbopelvic mismatch drastically improved to a 10. You can see significantly improved lumbar lordosis. And in most cases, with restoration of lumbar lordosis, thoracic kyphosis also normalizes. And this patient, his pain was significantly improved, and he's able to walk a quarter mile without any assistive devices. So I will save this till after Dr. O'Connor finishes his presentation. Thank you.
Well, great cases. I'm gonna go ahead and share the presentation here. Okay. Hi everyone, my name is Tim O'Connor, and I'll be going over another flatback deformity case, looking at it through the lens of another more minimally invasive approach to these cases. Here are my disclosures. And so this case starts out with a 72-year-old gentleman who previously underwent an L4 to S1 fusion at an outside hospital, did well, but 8 years later developed progressive mechanical back pain. Back pain and lower extremity radicular pain were exacerbated by standing and ambulation, and his symptoms continued to worsen despite conservative treatment. And so here you can see an MRI with an axial cut at L3-4 demonstrating adjacent segment disease above his prior construct. And this is just another cut slightly lower. And so here you can see his standing films demonstrating a significant positive sagittal imbalance with an SVA of 14 centimeters. He has 10 degrees of segmental kyphosis at L3-4 above his prior construct and almost a 30-degree PILL mismatch. And so, in summary, this is a patient who presents with symptomatic single-level lumbar stenosis and segmental kyphosis at L3-4 above a prior fusion construct at L4-S1. And so this goes out to the audience. For this patient, what operative approach would you use for this? Okay, great. We can see the results. Okay, great. So, it looks like, there's a lot of good options available for this. You can go posterior, you can go ventral, you can do anything in between. And so with any operative case, generally we start out by defining the goals of surgery and what are the risks and benefits of our intervention. And so this was a great study published by the International Spine Study Group with a bunch of talented surgeons that looked at patients that were older than 18 with radiographic parameters that our patient would meet, including an SVA of 5 centimeters or greater. And what they found with this study was that in their cumulative patients, almost 70% experienced some complication, with over half of those complications reported as major complications. And so even in the best of hands, these large adult deformity corrections do carry inherent risks. And here they break down the rates of complications. And so when breaking it down by age, our patient would be at an even greater average risk of experiencing a complication. And so the question is, are there ways of achieving our surgical objectives while minimizing operative time and complications? So this was another great study that was put out by the ISSG, and they looked at complications when breaking it down by MIS, hybrid, and open surgical techniques. And what they found was that with the MIS group, these patients experienced significantly fewer intraoperative complications than either the hybrid and open groups. And so what we did for this patient was a more MIS approach, keeping that in mind, that we recently published on, which was a prone transpose approach. And so with this technique, we use specially designed bolsters that leave the abdomen free hanging and able to rotate the pelvis, which is particularly valuable at L4-5. And so here, this is a different patient, but it demonstrates a prone transpose approach using these bolsters. And you can see how you can drop down the iliac crest on one side to give you access to that disc space, sometimes obviating the need for angled instruments. And so back to our patient here, you can see how segmental lordosis was immediately improved just by positioning him in the prone position. And so on the left are his standing films, and on the right are him positioned in the prone technique before any intervention. And so using a specialized retractor system, we have this two-bladed anterior and posterior rigid fixation that we're able to use when the patient's prone, and then proceed with a typical lateral interbody fusion. And then keeping the patient sterile and draped in the prone position, the posterior instrumentation can then be placed immediately afterwards in the prone position. And here you can see the intraoperative images. And postoperatively, the PILL mismatch was corrected from 30 degrees to 10 degrees postoperatively. And segmental lordosis was increased by 20 degrees at the operative level, with significant correction in global alignment from a positive 14 centimeter SVA to 5 centimeters. And so this technique allows significant restoration of segmental lordosis in a single position approach to correct adjacent segment disease and flatback deformity. And this is a common problem that we face, and this is one option to increase segmental lordosis with a relatively MIS approach. Thank you.
All right, well, thanks a lot, guys. That was three great talks from you three. We are a little ahead of schedule and time-wise, so if anybody has any questions, feel free to chime in right now. we have not had any in the Q&A section, so nothing else. We can wrap up soon. The only thing is, if you want to stay on for your the CME, there will be a survey coming up you need to complete to get the CME. Otherwise, we will look forward to hearing the next talks next month. Here we go. We got a question before we call it a day here. Also doing intercolumn release versus PSO for adult spinal deformity correction. Dr. Polina, do you want to take that one since you have a little more experience with ACR, and I can offer my comments on PSO?
Yeah, so ACR is certainly a strategy you could use to correct sagittal plane malalignment or flatback deformity, and it certainly is used by many deformity spine surgeons, myself included. The issue, amongst other things, is that it creates a very disharmonious lumbar lordosis, or change in the sagittal alignment. So you go from sort of this flattened region in the upper lumbar, and then this sudden severe change in sagittal alignment, and then back to more flat orientation to the lower lumbar spine. So I do think it has a role. I do think the issues I've had, as well as others, is this disharmonious change in lumbar lordosis creates issues in and among itself in terms of PJK. I think the patients seem to feel this abrupt change in lordosis in terms of their posture. It does require a special skill set for lateral surgeons. It does have I think a significant potential for major vascular injuries for those that are less experienced or don't anticipate the vascular anatomy and its orientation, namely its adherence to the annulus. So while it can provide sort of improvement and significant change in lumbar lordosis, I do think it's something those of us that do a lot of lateral deformity or hybrid surgery have used less and less in our practice, at least for myself, because of the reasons I stated.
Yeah, thanks for that. I agree. I think the big thing is the Justice's slides where he showed that about 2/3 of our lumbar lordosis typically comes from L4 down. And so if you're doing ACR, you're almost always above that level. So it's sort of like the Roussely classification, like Dr. Polina mentioned, is disharmonious curves. This ties into the next question about how does the PJK, PJF rates compare in ACR versus PSO. I mean, I think they both probably have significant amounts of adjacent level disease that we are all aware of. I do concern with like those reasons mentioned that the ACRs probably have an increased rate of PJF. I think a lot of it comes down to the right tools in the right hands. But I err on the side of doing pedicle osteotomies. And in one of those pictures you saw, I also sometimes do extended PSOs and using a Schwab type 4 classification to sort of help maintain height while increasing that lordosis.
I think the thing to keep in mind here, while we introduced sort of two categorical concepts on how to treat these problems, really the most important thing is the principles, and the principles have to be adhered to, and then pick the procedures to get there, and understand each procedure has its own nuances, its own issues, if you will. But you must at least identify, understand, and execute the principles necessary to optimize patient outcome, and then let the procedures follow you thereafter.
I think that's sage wisdom, and with that, I think we can wrap up tonight. Okay, so thanks again, everybody. Have a good week, and see you next month.